I am Dr. Felice Gersh, your integrative OBGYN, speaking to you today from London, England, which is why I'm just a few minutes late. I just got back from a lovely dinner. So, we're going to talk about a very important topic. It keeps coming up, and that is how to use progesterone when you're using menopausal hormone therapy. I was thinking about how best to present this to you, and I thought it would be good to start back. A little historical data might go a long way to helping you understand why I am such a strong advocate for cyclic progesterone. Let's go back in history. Well, we did not even know much about hormones at all. We didn't know how anything worked in the body until in the 1800s, when it was discovered that there are organs in our bodies that secrete something that travels some other places, and other, things happen. And that was the very first inkling of what is now called endocrinology. Endocrinology is where you have a hormone that's produced in one spot by one organ, and then it travels in the blood to a distant site where some sort of activity occurs. Okay, I don't have my usual paraphernalia. So the bottom line is that in the 1800s, it was discovered that there were these secretions. And what happened? Well, they realized that women in menopause had these secretions coming from their ovaries. So the first hormone therapy was taking ovaries from cows and grinding them up and then creating a powder and injecting it into menopausal women, whether menopausal naturally or through removal of the ovaries. And it progressed over time to creating a product that was oral that came from placentas, and it was estrogen. And it was only in the early 1900s, in the 1920s, that the hormone estrogen in the form of estrone was actually discovered, and then 5 years later progesterone was able to be discovered as the molecule that we now know it to be. Well, in the beginning, we had no way to create bioidentical, human identical hormones. So I mentioned that they took estrogen from placentas and then created a tablet. And that was the first form of oral estrogen. No progesterone was given. We had no progesterone at all. We had just discovered progesterone a little while earlier. It was in 1942 that Premarin, and that was the first really commercially successful form of estrogen, which came from pregnant horse urine. And they named the drug Premarin after pregnant mare urine. Premarin, okay? And they would take the horse urine and they would dry it, make it into tablets. And that first pregnant horse urine that was called Premarin contained large numbers of estrogens, including horse estrogens, particularly one called equilin that never existed in human females. And then as well, the dominant estrogen that was human estrogen equivalent was estrone. So a very tiny percent was estradiol, the same estrogen that comes from our ovaries. And even then, it went through the liver, where even that would be converted into estrone. So just to let you know, in the early days, there was no progesterone given of any sort. It was just straight estrogen. And the purpose was initially to help women to feel better. But then in 1966, there was a famous book, Forever Feminine, that came out that declared that menopause, and of course it was based on current ideas of the day, menopause was indeed a hormone deficiency state that was completely corrected by giving estrogen. And it just became very popular. We won't go into more history with that. But what happened in the 1970s was that it was discovered if you gave Premarin, and it was in higher doses at the time, the most common dose was 1.25 milligrams. And with that dose, what happened? Well, it became obvious. Actually, one of my mentors when I was a resident, Dr. Harry Zeal, recognized that there was a higher incidence of uterine adenocarcinoma in women who were just taking this hormone at that dose. So then it was realized that if you added a progestin, and the one that was chosen for whatever the reason was medroxyprogesterone acetate, that developed into the drug that was Provera. So people were given Premarin plus Provera. The way it was given was Premarin was given at a dose of 1.25, or it was then reduced to 0.625 milligrams, along with 5 or 10 milligrams, typically for about 10 days, sometimes 12 days, of the Provera, the medroxyprogesterone acetate. And it was recognized very early on that medroxyprogesterone acetate, as were the other progestins of the day, the mimicking but fake progesterones, that they were actually harmful. They negated a lot of the health benefits that the estrogen, even the horse estrogen, provided, involving lipid metabolism, lipids, and other issues. So the goal was to give the smallest amount for the fewest number of days, and that was debated because the only reason they added the progestin, the medroxyprogesterone acetate, was to not elevate the risk of uterine cancer. That was the only reason. Well, fast forward, it was then found that and this was heavily debated at the time, that you could give that lower dose of Premarin along with 5 milligrams of medroxyprogesterone acetate in a combination pill, and many women did not have irregular bleeding, although many did. Some didn't, some did. It just made it easy to market and easy to sell. But it was quite debated at the time. Is this too much progestin, giving it every single day? And remember, at that time, it really was not recognized what we now know today, using bioidentical, human-identical hormones, and how much different the benefits are. But they did know that the medroxyprogesterone acetate had significant negative effects way back in the beginning. And that's why they were talking about giving the smallest dose for the shortest number of days of that drug. And it was really quite controversial whether it was acceptable to give it on a daily basis to try to prevent bleeding. Then we had the Women's Health Initiative, and preceding that, the HERS study. The HERS study was just like the Women's Health Initiative, using Prem-Pro, as I described it, Premarin 0.625 milligrams plus the medroxyprogesterone acetate at 5 milligrams in a combination pill. Actually, now that I'm remembering, it's 2.5 milligrams of the medroxyprogesterone acetate. I haven't prescribed that in so long, I just had to rethink the dose. When they gave the medroxyprogesterone acetate daily, they dropped the dose to 2.5, and when they gave it for the few days out of the month, they used the 5 milligrams. That's why it kind of got through, because there was so much negativity about medroxyprogesterone acetate, even back in the 1980s. So the bottom line is that in the HERS study, they studied women who had documented previous heart attacks or strokes. And then in the Women's Health Initiative, the women could not have been included in the study if they had a documented stroke or a heart attack. But other than that, they were very, very comparable patient study subjects. They were all older women. They had a lot of metabolic dysfunction, a lot of overweight women. So the bottom line is that they were very similar, and the outcome was very similar, which was that the medroxyprogesterone acetate did not appear in that older age group to be beneficial for cardiovascular health. What came of it was that, of course, hormones kind of stopped being prescribed in many circles, not in my office, but in many circles, it went away. And then it started to creep back in, and then it's been escalating in the last 5 to 10 years, especially the last 5 years. And what is this hormone regimen? Well, if you look at some of the studies that occurred after the Women's Health Initiative, the two studies that were the major studies, and they had some major flaws, but those were the two major studies, the KEEP study and the ELITE study. What I want you to know is that in both of those studies, they used cyclic progesterone. I think that's really important for you to know. Cyclic progesterone never left the radar of anyone. And it's like really important to know that. It was very controversial when they gave the continuous progestin, medroxyprogesterone, with the conjugated equine estrogen, the Premarin. So in those two subsequent studies, they used cyclic progesterone. So that is just really, I want you to take home that message that it was never established that this daily thing was a good idea. Now, what also changed? Well, now we have progesterone, human identical progesterone, not that unfortunate, really negative drug, that mimicky sort of thing of progesterone, which has a lot of negative actions in the body, which is the Provera, the medroxyprogesterone acetate. So it's time to rethink all of this stuff. And I wanted you to have that historical data because so many people think it was sort of written in stone that you should give progesterone every night. It's not written in any stone anywhere, okay? In fact, the cyclic progesterone was what was used in the most major studies since the Women's Health Initiative, not nightly progesterone. So let's go into what is the reason for cyclic. Well, there's several reasons. One reason is dosing of estrogen. And I've touched on this before. One of the amazing benefits of estradiol, that's the estrogen that we use transdermally through the skin, is that it creates growth factors. These growth factors grow, maintain, rejuvenate, repair every organ system. You have to have these growth factors. In the brain, there are growth factors like brain-derived neurotrophic factor, nerve growth factor. We have transforming growth factor. We have vascular endothelial growth factor. There's so many growth factors, and they're critical for all these maintenance, growing, repairing, and so on, restoring all the tissues of the body. And it's one body, it's a whole. If you want to have optimal effects, optimal utilization of your estradiol, dose matters. A dose matters in everything. We don't say use the most minimal amount of vegetables in your diet. Use or obtain the most minimal amount of sleep. We don't say minimal, we say optimal. And that's what I say for estradiol. If you want optimal estradiol, you have to dose it in an optimal dose. It's that simple. And it's not going to be some tiny little dose that still stays in the menopausal range. We have to get over fear of estradiol. There are many things to be afraid of in this world. Estradiol should not be on that list, okay? So you have to get adequate amounts of estradiol. If you get adequate amounts of estradiol to do things like grow bone, and by the way, there are studies published showing that the effect on bone, shocker alert, is dose related to the dose of estradiol. You'll have better bone support and better potential for bone growth if you optimize the dose. Okay, so if you optimize the dose for every organ system and you have a uterus because nobody took it out, you didn't have a hysterectomy, you're going to rejuvenate the uterus. It's just part of you. It's okay. It's a sign that if you grow the uterine lining, you're growing bone, you're growing new neurons, you're restoring your cells, you're doing everything right. So you have to see it and frame it in your mind like this is a good thing. Because remember this little motto, if you grow it, meaning the uterine lining, you must shed it. You can't indefinitely grow the uterine lining. And if you give an adequate dose to create adequate growth factors, giving a little bit of progesterone every night will not suppress the growth of the uterine lining. And you don't want to suppress it because if you were actually able to suppress the growth of the uterine lining, you would be suppressing growth factors in your brain, in your bones, in your skin, in your arteries, everywhere. You don't want to suppress your growth factors. You want them optimized. You want to have them so that you can rejuvenate. That's if your goal to go on hormones is simply to suppress night sweats and hot flashes, this entire conversation is not for you because then it's the lowest dose, the simplest regimen. But if you're looking for optimization of every organ system, then dose matters and rhythm matters because you have to shed that lining of your uterus. If you grow it, you must shed it. And you want to grow things, restore things. That's one of the beautiful things about estradiol. But it's even more complex than that. Progesterone and estradiol up and down regulate receptors, and it's in a dynamic, rhythmic arrangement. We are rhythmic creatures. We're beautiful rhythmic creatures. We have circadian rhythms, we have seasonal rhythms, and we have lunar rhythms. The lunar menstrual cycle is a 28 plus or minus a little bit cycle. And what happens when you have the beginning part? Estradiol alone will increase its own receptor function. It will upregulate testosterone, progesterone, and thyroid receptor function. So all those hormones will work better, more optimally. And when you have the progesterone on board, progesterone downregulates testosterone receptor function, downregulates estrogen, particularly the alpha receptor function, to stop growth and proliferation. Okay, so you have this beautiful dynamic between these different hormones. And that is what is optimal for having optimal health. So we cannot recreate a physiology that doesn't exist in nature and think you're going to have a fantastic outcome. My best analogy is thinking that we could outsmart Mother Nature with ultra-processed food. That has not been a great experiment. That has not worked out well. We cannot create hormone regimens that never exist in nature and then think we're going to have a better outcome than if you somewhat, not identically, somewhat replicate the rhythms and levels of hormones that a healthy young woman would have. Because remember, I mentioned this in the past, every cell in your body is a different age. You only have a small number of cells that were there from the day you were born. That's why we have stem cells. Cells die, and then they're replaced by new cells. That's one of the reasons you want growth factors, so that you can replace old dead cells with new, beautiful, healthy cells. But that requires growth factors. So you need to have this beautiful dynamic. And progesterone downregulates certain receptors, and I mentioned testosterone. Why would you want progesterone every single day? You're downregulating your testosterone receptors. We know that women, when they have progesterone in the luteal phase, the second half of the menstrual cycle, it decreases their sex drive. So that's the last thing we need to have. We want to be vibrant. We want to have all of our receptors optimized at the right time. And then when the progesterone is ended, it's like a reboot. When you shed that uterine lining, which is like a menstrual period, you're not fertile, it's real blood, it's induced by the hormones, so it's not like a real menstrual cycle, which would involve ovulation. There's no ovulation, but it's real blood. That should be celebrated, that everything is working optimally. If you want to have cells that know what to do, remember, when a cell is born, it doesn't know how old you are, and all the cells of your body are different ages. They'll do what they're designed to do, the same as when you're 25, if they can get everything the same as when you're 25. Now, the answer is no, we can't do that. You are aging. We're not making the clock freeze or turning back the clock, but we can do a whole lot better. We're not unrealistic. Everyone is aging, but we can age slower and better. Medical probability. There's no guarantees with anything. I deal in medical probabilities. I'm just trying to improve our odds as women of living really high quality lives as menopausal women. And you're not going to do that if you have minuscule doses of estrogen and progesterone every night. We need to have these beautiful rhythms. We need to have our genes that are turned on and off. We have tumor suppressor genes that are turned on when you have the different amounts of estrogen and progesterone. The body is not designed to kill us. It's designed to keep us optimally healthy when we have the right hormones and the right hormone balance. So we cannot recreate a menstrual cycle. We're not going to have a real menstrual cycle, but giving a little bit of progesterone and a little bit of estrogen, you have to keep the dose pretty low so that you won't grow the uterine lining, is counterproductive to optimizing healthy longevity probabilities. I know it's annoying to bleed each month, but it's not that annoying compared to having an osteoporotic fracture, having dementia, having a stroke, having a heart attack, having incontinence, having prolapsed uterus. I mean, I can come up with a whole lot of scenarios that are a whole lot more annoying than having a few days of bleeding every month. And you can also manipulate it so that you don't bleed on a vacation. So it's not like we can't play around with it a little bit. So you must cycle your progesterone. I did not create the menstrual cycle, and there are many studies, many that really want to do cyclic. Remember, the progesterone that we use now is real human bioidentical progesterone, which has so many health benefits, unlike medroxyprogesterone acetate, which was found way back in the beginning of its use to have negative effects. So don't ever get those two mixed up. They're very, very different creatures. And real human bioidentical progesterone is wonderful for our bodies, whereas medroxyprogesterone is really a toxic chemical. So don't get mixed up. We want to have hormones that are human identical. We want to have them in levels achieved in our bodies that are somewhat similar, not the same, but somewhat similar to what a healthy woman would have. And we want to have the hormones in a somewhat similar rhythm to allow genes to be expressed properly, hormone receptors to be up and down regulated appropriately, and to have growth factors expressed and utilized that will help to keep our bodies optimally functioning. Cyclic progesterone is what was the thing back when these other studies were done. And it really is what nature gave us as women. Embrace our beautiful rhythms and don't fight them, accept them, and you will, I don't think, ever regret it. So think about it. What are your priorities? If optimizing medical probabilities for healthy longevity is your goal, in my opinion, having a cycle and using cyclic progesterone to somewhat mimic, somewhat, not identical, somewhat mimic what a healthy young woman in her 20s would have, that's what I would want for me. So give it some thought. Do what you think is best for you.